So once again, it's good to be here. And UNCDF is implementing a program on leaving no one behind in the digital era. Now, I had some colleagues on earlier, so some of the attendees on this forum might have heard about the work that we're doing. And just to give some context, leaving no one behind in the digital era, we think is fairly self-explanatory, but it's also not good to make assumptions. The background here is that while several of us are using digital platforms, digital service offerings to access information, to access services like healthcare and education, there are those who are in danger of being left behind. And these include refugees, migrants, rural farmers, small businesses. And so what we are doing is undertaking several interventions that are geared towards ensuring that these communities are not left behind. Now, one of the sectors where we work in several sectors, including agriculture, health, and education. But I thought that for this forum, we would focus mainly on our work in the healthcare sector. And so what I will do is provide a few examples of the work that we're doing that is contributing to the provision of financial solutions for these rural communities. Allow me to say that this entire program is being implemented in 4 work streams. On the one hand, we are ensuring that there is an enabling policy and regulatory environment. So you can imagine in healthcare, if a rural community member she might want to pay for that service using mobile money, but she wouldn't do that if the policies in place do not allow her to do so, if there's high taxation, for example, or there's policies on privacy that don't allow her to access that service. So we work to ensure that there is an enabling policy and regulatory environment. We also look at enabling an open digital payments ecosystem. And by that, we mean that, the mother taking her child to the clinic to receive immunization should be able to pay for that service using digital financial services. And so the hospital should accept those payments if the ecosystem is indeed open and vibrant to allow for it. Thirdly, we try to build digital literacy, that if underserved communities are indeed able to access and use digital service offerings or digital products to access healthcare, they need to have the literacy to use these services. And so we undertake interventions that aim to build literacy. And lastly, we try to encourage inclusive innovation. By that, we mean that as innovators, as people who come up with new business solutions, new service offerings in on digital platforms, as they come up with those service offerings, they should take into account the circumstances of those underserved communities. So solutions that only need high-speed internet or the latest devices would not really fit the circumstances of that rural farmer or that mother trying to take her child to a health center. And so those are the 4 work streams where we work. Now, in providing different services, in encouraging uptake and usage within those different work streams, we are undertaking what's called a market systems development approach. And by that, we mean that we work very closely with different stakeholders within these markets to ensure local ownership and sustainability, that these market actors should be able to take on these solutions and solve these problems, even when UNCDF is not in the picture. And so it is in that context that we have undertaken several interventions that really contribute to financial services for those underserved communities, and especially in the context of healthcare. Okay? And so the first example that I will share with you is work that we have done in conjunction with BRAC and working with the village health teams. So in Uganda, primary health care in the rural communities primarily delivered through village health teams. These are community health workers who might approach at the doorstep and carry out various assessments in order to refer patients to health centers or even give advice and collect information about different households. But for the most part, these village health teams are volunteers. Okay, that means that they are not paid, and therefore it's not really a sustainable business model. So what we've done with BRAC is to figure out what are some business models that would allow these village health teams to operate in a sustainable manner. And so we have, with BRAC, empowered these village health teams to have access to digital tools that they use. So on a device like this, they are able to go door to door and carry out the different assessments that they do. But in addition to that, they've been empowered with tools that allow them to, provide different services to different community members at the doorstep that they otherwise might have paid for. For example, if the village health worker, if the community health worker goes to a household and there's a need for oral rehydration salts, and this has been found out during an assessment at the doorstep, that village health worker is able to provide that product at a subsidized price. So that's just one example. Another example is, you can imagine if this village health worker does an assessment at the doorstep and discovers that this person needs a mosquito net. This is again something that they can provide. And so these types of tools allow these village health teams to generate an income, but also to be able to do this work sustainably and not necessarily rely on development agencies that might have grants or programs ongoing that are paying for the salaries of these village health workers. Now, by partnering with people like BRAC, we've been able to incorporate tools that allow them to save and access different financial services, again, enabling them to operate more sustainably. Another example that we have, another intervention that we have undertaken that is allowing for different financial services to be extended to the last mile to these rural communities is around an initiative where we are encouraging large companies that are big players in the digital space to open up their APIs. Now, several of you will be familiar with that. Those are application programming interfaces that allow a service provider, that allow one program to talk to another program. That's all they are. But by encouraging open APIs, we are encouraging banks or mobile network operators to enable financial technology companies, fintechs, to access certain service offerings, certain workflows from the core networks of these companies, and to extend services to last mile communities. Now, in doing so, some of those financial technology companies are actually extending financial services. A very good example of this, again, in healthcare, is a company called Clinic Pesa. Now, Clinic Pesa provides several payment solutions, and many of you might be familiar with them. They provide several payment solutions related to the healthcare, provision of healthcare. And so they allow different community members to save in a digital wallet and to save towards access to healthcare. However, some of these saving tools also allow the individual to access those resources for other emergencies. And so once again, here we see an example of financial access, financial tools for rural communities. Let me provide one other example. Just as I talked about access to healthcare at the doorstep, primary health services that are provided by village health teams. We have also worked with several private sector entities to pilot and scale the concept called digital community entrepreneurs. Now, these are individuals who might be leaders in their communities. These are individuals who will already be knowledgeable to different community members. And as I talked about earlier, that one of the goals that we have, one of the things that we try to do is sort of encourage this open digital payments ecosystem. That can't happen if devices and knowledge about service offerings is not available in these rural communities. And so with these village health teams, my apologies, with these different digital community entrepreneurs, they are able to also operate at the doorstep level. Did I lose the connection? Stephen, can you confirm that I'm still on?
You are still on. We can hear you
okay.
loud and clear.
All right, good. Yeah, so as I was saying that because these digital community entrepreneurs are able to go to engage at the doorstep level and to promote the use of digital products, digital service offerings, like if they talk to somebody at a certain household and that person doesn't have access to mobile money or a SIM card, they are able to provide knowledge about that and actually provide that device or that sign up for a SIM card or the sign up for mobile money account. And by doing that, they are able to earn a commission from the mobile network operator, from the bank that's extending banking services. And so here again, you see a solution in which through these digital community entrepreneurs, we are able to not only build rural communities' knowledge about digital services and digital products, but actually in the process, we're also able to encourage the extension of financial services for these rural communities. So an individual who might not otherwise have access, say, mobile money, through a program like the Digital Community Entrepreneurship Program, they are able to learn about these financial services. They might be able to sign up. So we're not only building last mile knowledge about these services, but also now encouraging last mile access and usage of these services. And as many of you are aware, the access to digital financial services has by far been one of the most successful ways to close the gap in financial inclusion. And so this, again, is another example of intervention that UNCDF has taken on to try to encourage and build access to finance, access to financial services within these rural communities. Now, what I've provided for you are 3 examples there. One focusing on village health teams, who are the primary provider of healthcare at the doorstep in these rural communities. The other looking at working with large players within the digital ecosystem like banks, like mobile network operators, to provide APIs that allow fintechs, financial technology companies, to extend services to last mile communities. And some of these services will include financial services. And lastly, I've talked about our work with private sector companies to build out networks of digital community entrepreneurs, individuals who are operating within the community and at the doorstep level and extending the knowledge about digital products and service offerings to the doorstep to last mile communities, and in the process also helping to extend access to financial services. Thank you so much. Over to you, Stephen.
All right. Thank you, Chris, for that. I think the use of examples brings to life some of what has been said today. Yeah, Rema, are you ready now?
Okay. I'll be presenting on the implementation bottlenecks of real-time medication monitoring made for improving adherence to anti-TB drugs among tuberculosis patients in Kilimanjaro, Tanzania. So, You can see the real-time monitoring device, the EveryMate. Once it is open, you can see there's a drag and also the battery part where there's a sensor which senses the opening of the device. And you can see when it is closed, it blinks a green light, which makes it that the the status is okay. It can send the report of the patient adherence. So what it does, the EveryMed. So the EveryMed, this device was used to remind patients to take their medication. So we send the message 30 minutes before and 30 minutes before intake, and also if he or she forget to take the medication, then 30 minutes after the time we set, it send another message to the patient and the treatment supporter that forget to take medication, then he or she should take the medication. So this device also, depending on the network availability and the power, but it has battery which was providing the battery which was near to the sensors when it is open and close of the device. So this was the reports which was generated by the device. You can see there's a green. I don't know if you can see.
Yes, we can see.
Okay.
Maybe do you want to just make it a slideshow because it's a bit small.
Okay.
So for the benefit of our eyesight.
Okay. I don't know if you can see it, but this was the report which the report which was generated, and these dots means that he or she take the medication. The patient open the device and take the medication. So we had we can see there's a green dots and the black dots and the blue dots. The blue dots, it indicate that a patient open more than once, the extra openings which were counted. And also we can see that the black dots was exactly time of the patient take the medication on the exact time. The green dots, it means that the patient take the medication before the time the time which was set for the medication. You can see the pie charts at the end. The green ones means that the patient was adherent and take all the medication on time. The blue ones, as I already said, those was the extra ones. This was another report which was for example for the patient who was not adherent to the medication. You can see there's no dot. And these reports were generated monthly. You can see the whole month was the patient did not take the medication. And the red pie, it shows that there's no intake for the whole period. So by introduction, the digital adherence tools, it includes the real monitoring device and the short SMS, the SMS reminders. So the DAT have been reported to improve the medication adherence among TB patients, and as described as promising tools to monitor patient medication in the resource-limited settings such as Tanzania. However, there's a gap and resource limited on the evidence of feasibility and the effect of the adherence. So this study was, the main objective was to assess the potential implementation bottlenecks of the real-time medication monitoring using the EveryMed, the device which we used. So first we conducted a mixed method study, which we assess the technical bottlenecks of implementation of EveryMed among the TB patients in Kilimanjaro, and for those who participated on the Remind TB trial. We calculated the percentage of sent and delivered SMS reminders and the daily device activity status. And also, we did the in-depth interviews to the TB nurse and the clients to assess their experience, perception on the EveryMed usage. So this was results which we found. We had two arms, the one who used the EveryMed and the control arm. So 266 participants received the EveryMed device. You can see, according to the pill count, the level of adherence in EveryMed was 86%, while in control was 78%, which means that the EveryMed was effective. But also we noticed the technical challenge was out of the SMS which were sent, only 50% were delivered. And also, the mean percentage battery per month for all the device, 45% recorded medium battery, 6.7% the device were recorded in low battery, 2.6% also recorded very critical battery, which lead to loss of data because we couldn't see. You can see in the next slides. I'll show you how this affected the results for adherence. The bottlenecks reported from in-depth interview was included difficulty in assessing the online adherence reports due to limited knowledge of mobile technology. This was main challenge from the dot nurses were support from the reports which were generated. We sent to the dot nurse so that they can discuss the feedback with the patients. But there was a challenge that they couldn't assess the report. Also, there was another challenge of poor network coverage, especially in rural areas, and also there was unreliable electricity in some of the areas. So you can find that the device is battery low, but when it can't be, we can't charge. They can't charge the device because of the unavailability of power, especially in rural areas. And this study was all Kilimanjaro from rural to urban. And these are some codes which, example, one client say that when there's no network, they send you message because they have seen this tool not reporting. So we found that because the patient was not in the place where there's network, so we found that the second message, which I already explained, that if the patient did not take the medication at the time of medication, which we said, there was another message which came, another message, the second message, that you forget to take the medication. So these messages were coming, but in reality, the patient already took the medication. It's just that there was a problem with the network. So also this affects the adherence reports from our side. This device also, there's another client which accepted this device, said this device is good, but it gets to the point where the reports going to the system of the device is delayed. And so when it is delayed, it means that we see that the patient did not take the medication, but the real problem was the network problems. So from our side, we can see when the battery status, example, we can see there's a list of clients, and you can see the clients with 0% also reported zero adherence, but this was the challenge of the power which we faced during the study. So in conclusion, say this study reveals some important technical feasibility information on the EveryMed technology, especially in our setting in Tanzania. Future studies using this real-time monitoring device should consider issue of network availability and also improve the device battery life. Maybe it can last even the battery life even up to 1 year, or even the whole course of the TB medication more than 6 months. Also, strengthening on the training and sensitization on the mobile technology to healthcare providers, because they are the one who introduce or deal with a patient directly. We should strengthen the training more on how this technology works. Will also help. Example, when in attaining maybe the generation of the report, so they can discuss feedback with the patient or the client. Thank you.
Yeah, so maybe I'll just from a perspective of what Chris and Dr. Peter and Rem have shared, the issue of quality control. Both Peter and Rem shared specific to TB, whilst Chris was a bit more general around inclusion. But I think quality is something that cuts across. So I wanted to just maybe if the panel can just speak to quality control, with the whole decentralization of health services, how do you guys, what do you envision as enabling that kind of right balance and by extension enabling e-health in East Africa? Maybe we'll start with Dr. Peter.
Okay, sorry, I didn't get you clear. Sorry.
No, I was just talking about the notion of quality control. So I was just talking about the fact that with e-health, and in your case, healthcare outcome, the healthcare outcome project that was specific to TB in Tanzania, and for Rehema it was about real-time medication monitoring for improving adherence to anti-TB drugs, and then to Chris it was financial inclusion. But I was just saying that quality control is, I believe, is something that cuts across when it comes to e-health. So, given your respective insights that you have presented today, what are your thoughts on quality control, especially around the fact that with e-health comes a largely decentralized healthcare system? So, how do you balance the need to grow or to deepen e-health versus the safety of citizens?
Okay, thank you. In our case, when we decentralize the MDR-TB services, the issue was to change from the hospital mode of care to a home-based of care. So now what we look is at what time the patient is starting the medication. Initial patient used even to stay more than 1 month while waiting the team or waiting the logistic to send the car and pick the patient to bring the patient back to. So now, when we are using the virtual community of practice, now what we usually do is just an addition of what was done here, also done previously. Previously, we healthcare workers were capacitated physically. We used to do on-site training. Thereafter, they continued to manage a patient. But since decentralization, now what we usually do, the healthcare workers from the where the patient is, they summarize clearly the patients. And the expert team at the hub, they listen to the case. So if there is any result, they help them to interpret the result. And thereafter, we give the recommendation on what regimen the patient should be initiated. And we don't end up there. We do the follow-up. Maybe after 3 months, the patient will be also presented to bring back the follow-up at the follow-up. But we say that this virtual community of practice is an addition of other ongoing project, because there is other continuing project where there are some of the non-government organization collaborating with our national TB control program. They're still doing the physical visit of the site, so that in our side the virtual really reduce the duration of starting the MDR-TB treatment, but also when the patient has a complication will be discussed during the session. So we say that a real-time management of in case of any complication when it's come. I think I can respond on that. Over to you. Over.
Sorry,
Steven,
Stephen, you're
you are.
muted.
Oh, sorry, no. I was just saying, I was just inviting Rehema to give her thoughts. Or Chris?
Rehema, do you want to go first?
I would like to say, for us, the addition of digital, I don't know if I understand you well, but the addition of using the real-time medication monitoring was addition of quality to the standard of care, which they did from the care which is normally doing to the hospitals. So this addition of real-time monitoring helped even the nurses to help to track their patients. So it helped with even the quality in providing the care. Over to you.
All right, thanks, Rehema. Chris?
Thank you so much. Indeed, with the examples that I provided, quality control, you're absolutely right, very important point. And with each of our partners and with each of our interventions, we do incorporate an aspect of training so that implementing partners as well as beneficiaries receive training on the usage of the tools that we provide, that we're piloting in these communities, that we're empowering them with in order to ensure that there is, in fact, quality delivery in these services. That's one. Secondly, this applies to, for example, the work that we're doing with BRAC, where they are, working with, their networks of village health teams, these community health workers, to use technology solutions to provide care at the doorstep and in the process provide different services and generate income. There is a level of training that's provided to ensure quality in those cases. Secondly, in cases where we are working with different stakeholders within the digital ecosystem, so providers of infrastructure, like mobile network operators, like banks, there is extensive testing of their own APIs so that when they are provided to these fintechs, to these partners who are providing solutions at the last mile, there's standardization of documentation and what have you to ensure that indeed there is a level of quality in delivery. That being said, we also, as UNCDF, provide quite a large amount of technical assistance to our implementing partners to ensure that the business models that they put forth and the services that they provide, in many cases, these have an element of financial services to last mile communities, that indeed these are providing value and that they are sustainable and able to solve the problems that were purported to be addressed by the service provider. I think that's all I can say about quality assurance, quality control. And over to you, Stephen. Thank you.
All right, thank you, Chris. I'll just check and see. Okay, so there is a question from Felix Kalisti, and I encourage the audience to please share their questions. So Felix is asking, I would like to know from the panelists, how is the adoption of presented digital tools affected by the users' levels of digital skills or literacy? And I think Chris just spoke to that, but maybe you can just reemphasize what you were saying, and maybe the panelists. So Felix would like to know how the adoption of the digital tools, how the adoption of the tools presented is affected by the users' levels of digital literacy or digital skills. I think that is to you, Chris.
Would you like me to go first? So it's absolutely right that indeed we have seen the digital literacy as a major gap in the adoption and usage of digital service offerings by different communities to improve their productivity and well-being. And so you're absolutely right that that is a major barrier. What we have done to address that is that in tandem with these different interventions, we have also taken on partners who are offering innovative approaches to building digital literacy within these communities. We have worked with different partners to adapt existing curricula to deliver digital literacy to refugee communities, to women, to small businesses. And we are also working to ensure that there is practical application. So it's not just digital literacy in space. It's digital literacy as applied to, are they able to open a bank account? Are they able to, if it's a village savings and loans association, are they able to share information amongst themselves? Are they able to carry out different functions of that VSLA using a mobile device? How does that save them time, and how does that make their operations more secure? So it's building digital literacy alongside various use cases that are relevant to these communities. And in that process, addressing the issue of digital literacy, which is indeed an impediment to access and usage of digital service offerings by different communities. So that's some of the work that we've done to address that. And you're absolutely right. It is an impediment that needs to be addressed. Thank you.
All right, thank you, Chris. Maybe 2 minutes for any closing remarks from the panelists. Peter, Rehema, and then Chris.
Yeah, I think I would like to thank you for giving us this opportunity, and we thank the organizer. The meeting is going well, and we hope most of the findings provided by the presenters probably will be published and will be shared within the other region and in our East Africa region, so that as we can see, the world now is heading to digital. Everything is going now to be digital. So we hope, we thank organizers, and also we would like to get another invitation for future meeting. Thank you.
Thank you, Dr. Peter.
Yep. Yeah. Thank you very much. I have no comment, but thank you so much for the invite, and I appreciate being in the panel. Thank you.
Thank you, Rema. Chris?
Yes, thank you so much for this invitation to be part of this discussion. My remarks really center around, again, as I mentioned, that there are several communities that we're working with that are really in danger of being left behind. I think that the work that we're doing is very similar to what others are doing in encouraging the uptake and usage of digital services, digital products, or digital service offerings, really to improve access to healthcare. Now we're doing this in other sectors, but I really want to commend, first of all, my fellow panelists for their work, but also others on this forum. I think that it's very important work. And I think that no other time than now, as we go through this pandemic, as we face these challenges, do we see and recognize the role that digital service offerings and digital platforms play in improving our access to healthcare, improving our access to other basic goods and services. And so this is a call to action. For those out there, UNCDF is a ready and willing partner to those who are working to ensure that underserved communities have access and usage of digital platforms to improve their livelihoods and well-being. And indeed, look forward to additional collaboration and networking after this to enable that to happen. Thank you all so much.
Thank you, Chris, Rehema, and Dr. Peter. That is it from me. I'll also sign out. and I look forward to going to the exhibition. And yeah, thank you once again for having tuned in.